Let me please welcome Dr. Sankalp Singh for the keynote on the topic Surprises in IVF to share the unexpected twists and takeaways from the world of assisted reproduction. Dr. Sankalp Singh is a reproductive medicine, infertility, and IVF specialist in Indore. He is a reproductive medicine and OBGY specialist with 20 years of experience. His keen interest in academic teaching, and also he has vast experience of teaching obstetrics and gynecology and reproductive medicine. Over to you, sir.
Thank you very much for the kind introduction. Respected chairperson, seniors and colleagues, very good morning to all of you. And thank you very much, Jayakrishan sir, for inviting me for the talk. And since I've been in Kerala for 12 years, it's always a homecoming for me, and I feel extremely happy to be amongst all of you. So the topic for today is surprises in IVF. Now, what kind of surprises? So we'll be discussing about unexpected poor ovarian response, asynchronous cohort of follicle during stimulation, premature LH surge, and poor quality oocyte at retrieval, what went wrong. So these are the topics which I have taken because these are difficult ones, unexpected ones, and it's like managing them becomes difficult when we are sitting in front of the patient, what exactly to tell them, how to tackle it, what explanations can we give which can be accepted. So coming to case 1, that is unexpected poor response. So a young couple, wife 28 and husband is 30 with normal BMI, unexplained fertility, recruited for IVF after 3 failed ovulation induction IUI. Husband had normal semen parameters, wife had normal AMH and AFC. So stimulated with flexible ANTAC protocol with 150 unit of recombinant FSH. Scan done on stimulation day 5. Out of 20 antral follicles, 5 grew. So the dose increased to 225 and 75 units of LH was added. On final day, that is day 9, she had 5 follicles. We got 5 eggs, 2 day 5 embryos, and the transfer was done and beta HCG negative. So this is the kind of case which we discuss, and this is not something which is uncommon, and especially these days it is pretty common to see unexpected response. So to this lady, when we stimulated, we wanted to get more follicles, and at the time of pickup we have more number of eggs. But to our dismay, when we start, we'll be getting say around only 3 follicles visible, and then we'll be facing this situation in our OPD when the patient would be asking us genuine questions. So this topic is important because AFC or AMH based prediction of ovarian response are not perfect. False positive in 15 to 20%, and only 60 to 70% of truly out of normal responders would be identified. Unexpected response is seen in 1 in 5 patients in age 25 to 35 years. And IVF success depends on the number of oocyte. So flow of this particular talk would be causes, evaluation, rescue in the index cycle, management of the next cycle, prevention in the first cycle itself, and conclusion. So the ideal number of oocyte what we want after COS to maximize live birth rate is somewhere between 10 to 15. That's what we usually aim for. The causes of unexpected response can be iatrogenic, that is improper dosage, reduced bioactivity or limited pharmacokinetic availability of the drug. Then theoretical causes, which are the circulatory disturbances of the ovary leading to altered drug distribution, low androgen, smoking, and practical and correctable cause, which are cohort issues, environmental toxins, and the genetic polymorphisms. So environmental toxins these days are something which are coming up in a lot of researches. So this particular study showed that when there is low intrafollicular benzene level versus a high, the response to the ovarian stimulation is less and the chance of poor response becomes higher. Genetic polymorphisms, so there are various types, FSH receptors, polymorphisms, and single nucleotide polymorphisms, then LH receptor polymorphisms, and LH receptor beta polypeptide, that's another variant of LH hormone. So how can a FH receptor polymorphism affect the ovarian response? So it alters the pattern of receptor expression, it reduces affinity towards FSH, and alters the production of the secondary messengers. Most common FSH receptor polymorphism is the ASN680 serine, that is RS6166. That's the name. That's the commonest polymorphism. It has 3 genotypes: serine, aspargine, and the aspargine. And the most common is the serine, which is the most notorious, where the response is usually the least. This is also one of the reasons in PCOS patients when they don't respond to ovarian stimulation, and we think that why is this lady not responding? So she might have more follicle, but if she has the polymorphism, the FSH receptor will not respond. So the most common problem which it gives is hyporesponse in FSH as per all these studies. This is meta-analysis of 16 studies. The number of oocyte retrieved was significantly lower. How can you suspect it? The only way practically which we can say is high basal FSH. So that's one of the things which we can look for still in the age of AMH and AFC, that when you have an issue, just check your basal FSH. If it is more than 10, with a normal AFC, there is a mild possibility that she might be having a receptor polymorphism. Coming to LH receptor polymorphism, LH variant has been found in 32% of IVF candidates with hyporesponse profile, and the V beta LH is characterized by increased bioavailability but very short in vivo half-life, leading to lesser number of oocytes. How to rescue or manage it? So we'll discuss in index cycle, that is in present cycle we have two options, increase dose and add LH. So the studies which have compared these outcomes, what they have shown is addition of LH significantly improved the live birth rate in such patients. Another study, 260 women RCT, where 130 had inadequate response and 130 had normal response. Those 130 who had inadequate, they divided into two parts. 65, they stepped up the FSH by 150, and the other 65, they added the LH by 150. And what they found was when they added up LH, the pregnancy rate was as close to the normal responders as possible, that is 32% and 40%, while adding FSH, the increase was very, very minimal. So next question comes is how much LH should we be adding? So the options are either 75 or 150, and this study has shown that 150 gives a higher oocyte number and a better clinical pregnancy rate in such scenarios. Another meta-analysis of 5 studies, what it showed was that the oocyte number, when you compare recombinant LH addition versus just the FSH addition, the oocyte number is higher and the clinical pregnancy rate are higher. So why they need LH, why they don't respond to the endogenous LH which is already in circulation? As we know that all of us, our blood has LH, so why it just doesn't respond to it? Because increased resistance to the gonadotropin stimulation, functionally deficient endogenous LH molecule, LH receptor might be deficient, or that can be associated polymorphism of the FSH receptor promoter gene. Coming to the management in the next cycle, so next cycle we can either recheck the ORT, we need to assess the FORT and FOI which I'll be coming, then FSH receptor polymorphism testing, increased dosage and adding of LH. So rechecking ORT is very, very important to identify women who have a discrepant ORT. So some ladies might have a normal AFC but their AMH might be less, some might have it other way around. So we need to check all these three things, AMH, AFC and FSH-LH, and we have to give more. That's a rule of the thumb. If one test is abnormal, that test is more important than a normal test. So you have to decide your dosage based on the abnormal test. Follicle output rate or FORT, it's basically number of follicles which grow with COS compared with the number at which COS was started. That is number of antral follicle on day 2, you start the injection. So out of those, suppose you have 10 follicle, how many have grown? That is the follicle output rate, which that means more than 16 millimeter follicle. Follicular oocyte index, that is number of egg retrieved compared with the number of AFC. That is number of AFC, if it is 10, so how many eggs are we retrieving? So simply put, we should expect at least 70% of all follicles which we see on ultrasound on the starting of stimulation, that those 70% should grow and we should get an egg. So that's the bottom line. If you don't want to go into follicle FORT and FOI, just remember what you're seeing. If you're seeing 10, you need at least 7. That should be the ratio, which is fine enough. Coming to the study regarding the effect of dose adjustment. So compared to if in the second cycle, if you adjust the dose of FSH, that is you increase the FSH, so every 50 unit hike in the FSH, you will get one additional oocyte. So that's how you have to figure out how much dose increase is needed, because that will be decided based on what dose was she in her first cycle. Another study, what it did was that for all patients who had the polymorphism, they just made a blanket 300 unit of FSH. That they gave 300 unit of FSH to all the patient who had polymorphism, and then when they compared with normal, there was similar fold, that is similar number of follicles grew in all of them. So increasing the dose automatically corrected the defect due to which the follicle was not growing. Does the type of the FSH matters? So, study 382 donor cycle compared RFSH versus HPFSH. So, RFSH led to lesser number of oocytes, whereas HPFSH resulted in higher number of oocyte in patient who had the receptor polymorphism. The reason for that is the highly purified FSH has more acidic form, so that has a longer half-life, due to which there is longer duration of stimulation because it remains in the blood. That's the reason it gives. So if there is one indication of going for HPFSH or an HMG urinary product over a recombinant, then this is the one. So conclusion of the first case is reasons and evaluation. Hormone and functional predictor of ovarian response are not sufficient on their own. At least one of 4 women with normal AFC can have one of the FSH/LH receptor issue. Genetic phenotyping of relevant polymorphism is advisable after one expected POR before jumping to donor gametes. Conclusion regarding the treatment in index cycle. In women who have follicular growth stagnation, add LH in ratio 2:1. Previous cycle poor response, bottom line is give at least 300 unit of gonadotropin. You can give 225 plus 175 if you have not tested for polymorphism. Increase the dose of FSH by 50 to 75 unit if there is no polymorphism, and 75 to 150 if there is a polymorphism. V beta LH, you may benefit from addition of LH. Now, practically, then what you will ask is, this is too complicated. Can we make it simple? So, what I practically follow is that I don't do a receptor testing. So, I don't do any universal receptor testing. What I do in such cases is, usually my starting dose is always 75 units more than what I think is necessary. The reason being that especially for the first 3 days, then I use HMG for all the patients at least 75 units, because if there is an unknown receptor polymorphism, this LH is going to help there. I step down after 4 to 5 days if needed. So I call the patient 3 days after it, do the testing. If the response is more, I just step down. So always in IVF, a step down is better than a step up. Step up is fine in IUI, but not in IVF, because you'll have lesser number of follicles growing. And if more number of follicles grow, then simple, I'll give agonist trigger and freeze all the oocytes. And it will take care of any unexpected suboptimal response in majority of patients. So this is the practical thing which I am following since last nearly 7 years. Coming to case number 2, that is asynchronous cohort of follicle during stimulation. A young couple, they did not have any papers from previous IVF. 2 sites were retrieved from in the first IVF, and when we did her scan, in the left and right ovary, if you see, the right ovary showed one follicle of 9 millimeters, which was higher in size. So the antral follicle response, when you assess by the follicular output rate, this particular study showed that the 2 to 6 millimeter follicle, this denotes the functional ovarian reserve. So this is the one which we should be aiming for. If the follicle size is more than this, so when they compared the data, when the follicle size AFC was in this range, the p-value was most significant with the fort. So they correlated well with the fort. Another study which saw an antral follicle diameter variance, that is, if one follicle is 4, another is 7. So they checked the diameter. So they measured the diameter of the largest and the smallest follicle in a given cycle, and what they realized is that if the variance was more than 3.5, then that has a 75% sensitivity to predict a poor response. So if one follicle is, and the largest and the smallest, the difference is more than 3.5, then usually the larger follicle will grow and prevent the smaller ones from responding well. So how to get a synchronized cohort? This was covered very well by Raju yesterday. So physiological logic is you give OCP for 12 to 21 days or progesterone for more than 10 days. It causes the FSH and LH suppression for 48 hours, and their period comes for after 4 to 5 days. Whereas estradiol, it suppresses only FSH and the levels start increasing just the next day. So if you're giving estradiol pre-treatment, then what we do is Start it from around, if the period came, last period came on 1st of April, then start the estradiol on 23rd of April, twice a day, and give it till 1st of May. So periods will come around this time, then you can start this stimulation. If you are giving progesterone plus estradiol treatment, then you give progestrogens from around 18th day, that is the CL has already formed, and give it for around 10 days, and towards the end at estradiol twice a day. So that will take care of any FSH rise which can happen towards the later part, and then periods would come and then you start this stimulation. If you give OC pills, then give it for around 15 days starting from the second day of the period, and then give the estradiol for 5 days. That will again prevent any FSH rise post OCP stoppage. So period would come, but the follicle size will not grow, and then you can start it. So the studies have shown that there is no negative effect on the reproductive outcome. And if you see it a long protocol, it also helps in the synchronization of the follicular growth, but it has its own disadvantage that you need a higher, longer duration of injection, and you also have more injections FSH-LH needed. Coming to the conclusion of the second case, pre-treatment can be used with OCP/progestrogen, luteal estradiol, or long protocol. We need to weigh the advantage and disadvantage, and whatever used, it should be used in the minimum dosage. Coming to case 3, that is a premature LH surge. So the flow of the talk would be how the surge happens, what is the difference between premature surge versus a premature luteinization, the incidence of it, how to tackle it, and role of prevention of LH surge. So the regulation of induction of LH surge is by GnRH, estradiol, progesterone, and something known as GnRH surge attenuating factor. So how the LH surge happens is once the estradiol level rises, and once it crosses 50 and remains more than 50, crosses 200 and remains more than 200 for 50 hours and more, that triggers a LH surge. There is feedback from ovary by estradiol inhibin in the first and follicular phase, and estradiol progesterone inhibin in the luteal phase. So the question comes is, why only 25% of the patients have a premature LH surge? Why not everybody? That is because of GNSAF, that is gonadotrophin surge attenuating factor. So as the follicle size keeps increasing, the GNSAF level, it keeps reducing. So if you see the maximum GNSAF level is by the follicle which is up to 10 mm, then it slowly decreases and then it comes down when it becomes around 16 to 18. So this is what prevents the premature LH surge in most of the cases. Incidence of premature LH surge is 25% when you don't use any suppression, and 5 to 15% in antagonist protocol. So there are various terminologies. Premature LH surge is when the LH rises with normal progesterone before HCG criteria is met, whereas premature luteinization is LH rise with concomitant progesterone rise before the HCG criteria. So mature LH surge basically means that ovulation, that is release of the eggs. So when you are defining LH surge, so as term delivery was defined before defining preterm delivery, so for LH surge to be defined, for premature surge to be defined, we first need to know what is LH surge. Unfortunately, there is no consensus in the LH surge. There are various studies with various level 10, 15, 20, how many 2 or 3 standard deviations above, but there is no consensus. So the experts have come with a consensus of serum LH level of more than 10 and or an LH increase of more than 2.5 the basal level constitutes an LH surge. Causes are many, including high basal LH level, advanced stage, late start of antagonist, more than 24 hours gap between antagonists, and drug issues. How to manage it? So a very good article in 2014, what they saw was that what was the stage of the LH surge, how many hours, whether it's ascending phase of the LH surge or descending phase, how was the hormonal status, how much was the level of the LH and progesterone, and then they time the oocyte retrieval accordingly, that is 2 day late, 1 day late, or on the same day, and they gave the gaps as well, 30 to 36, 17 to 31. So that's how they did it. But is it that simple that we just do it and we get the follicle? We need to understand that for deciding whether an LH surge we should act or not, we need to answer these questions. Is the duration of and pattern of LH surge same in all women? So I will take it one by one. So the LH surge level is important. just with 5% rise in LH, the surge can happen, but it needs 85% level to have an ovulation being taking place. So there's a huge gap between the LH surge happening and ovulation happening. Is LH surge onset to ovulation or LH surge peak to ovulation interval, is it same in all the patient? So that when they check the data, they were most available studies were conducted several decades ago and which employed tools of ovulation such as dating of corpus luteum, laparoscopy, which are no longer used. And the time interval between the onset of the surge and the ovulation is variable between 22 to 56 hours. So the mean duration also differs from patient to patient. Is premature LH surge the only reason for early ovulation? Again, the answer is no. The main thing is the low number of follicles and the advanced stage. These are the two most important reasons. Is it proven beyond doubt that premature LH surge is pathological to IVF outcome? Again, a study of 730 women, it did not found a detrimental effect of a premature LH surge. Even when you give antagonist on alternate day or daily antagonist, again, it has not shown to be of a detrimental effect in the outcome. Because the more intense the ovarian stimulation, the higher the GNSAF level and the lesser chance that the ovulation is going to take place. And luteinization is not always preceded by an increase in the LH levels. Multiple premature peaks of LH have been seen with luteinization in about 30% of cases. And then is there a conclusive evidence that early OPU approach, that is most of those studies, they have taken the eggs early, whether that approach is helpful? So one study, has seen three groups. Group A, when there was no LH surge, they did OPU at 36 hours. Group B, premature LH surge was there, and Group C also it was there. So in Group B, they did OPU at 36 hours. Group C, they did early OPU. And what they found was there was no benefit of doing an early ovum pickup in such cases. So do we really need to be that worried? Will oocyte age due to just a premature LH surge happening? So the answer for this is that does a high progesterone level cause the poor oocyte quality? So absolutely no, because we are using duostim protocol and luteal phase stimulation, and it does not cause a detrimental effect. And in case there is a problem, we can easily add up a small dose of indomethacin. So answer to all these questions is actually no. So what practically I follow, and I have not seen a issue with that, is I go ahead with antagonist protocol. The starting criteria is 12 millimeter lead follicle. Antagonist dose within 24 hours of the last dose. So if today's dose is at 10, tomorrow's before 10. No need of any LH or estradiol testing. Indomethacin to be started 1 tablet 3 times a day if there are lesser number of follicles 2 days prior to egg pickup. 35 to 36 hours egg pickup, and I ask the patient to inform me if the pain increases by 50% on the day of the trigger. Case 4 is poor oocyte quality. So a young couple, they came for IVF and we did the COS and everything was perfect, but we got 11 GVs and 4 M2 oocyte with severe central granularity. So this is how the ideal human oocyte should be, but more than half of all the oocyte showed at least one abnormality. And then there is a fight between the embryologist and the clinician. So there is a continuous crosstalk which happens between the oocyte and the granulosa cell for the maturity. So the problem in the oocyte can be two types for the oocyte quality. One is maturity related and morphology related. So the maturity related, it can be due to trigger issues and like improper cold chain maintenance, improper administration, wrong timing, and agonist trigger in a long protocol. These are fairly correctable. The other one is the LH-CGR receptor issue, which is more challenging. So when the LH surge happens, the meiotic resumption starts within 18 hours, and with 14 to 27 hours, the maximal oocyte maturation takes place. The oocyte maturation triggers are these two. So when we give a standard trigger, 36 hours of the standard trigger, we do an egg pickup. When we give agonist trigger, there is a high chance of failure of agonist trigger in certain scenarios, which I have listed here. I'm not going to detail of that. When we get lesser number of mature oocytes, that's known as immature oocyte syndrome, when we get less than 25% mature oocyte. In those cases, how we can treat is either give a dual trigger or a double trigger, that is combine HCG and GnRH agonist. So to give a dual trigger, we do OPU 36 hours after an HCG and a agonist trigger. That's a dual trigger. What's a double trigger? We do the OPU 34 hours after the HCG, but 40 hours after the agonist trigger. That is, the gap is more after giving the agonist trigger so that the maturity of the follicle becomes much better. So the target patients are normo and poor responder and not in hyper responder. So when we give to LHCGR receptor, the HCG and LH both acts, but they have different receptor binding kinetics and they act in different way. So when we give a GnRH agonist trigger, FSH and LH both increase. FSH peaks at 8 hours and LH peaks at 4 hours. With the HCG trigger, the peak HCG happens at 12 to 24 hours. The advantage of a dual trigger in such cases where the maturity is less is because the agonist trigger, it kickstarts the initial oocyte maturation, and the HCG, it continues or rescues the oocyte maturation for a longer duration of time. So there is more exposure of the LH in the LHCGR receptor and more stimulation of the LHCGR receptor. FSH also is needed for oocyte maturation because it has differential effect and lot of other beneficial effect in the oocyte maturity. So clinical evidence, dual trigger 2.5 times higher chances of getting a mature oocyte. With double trigger also it reduces the impairment, due to which there is high number of oocytes which are mature and the pregnancy rate with double trigger is higher. Now coming to oocyte quality issues, there can be extracytoplasmic or intracytoplasmic, and these are the abnormalities. Lot of research done in that. An abnormal oocyte becoming an abnormal embryo and low IVF success, that's something which is controversial, because even a marginally abnormal oocyte can give us a pregnancy. The studies which have been done showed that there is no consistent pattern of morphological abnormality and the IVF outcomes. This is again a recent study of 2022 done on 76 papers. What it showed is there are 11 different dysmorphisms, extracytoplasmic and intracytoplasmic. Out of that, abnormal cumulus cells, vacuoles, SCR clusters, and granularity. These are the only ones which matter for the final result what we get. So egg quality should also mean a DNA assessment, but egg quality by morphology versus ploidy, unfortunately, there is no good study. Now, causes of getting a poor morphology oocyte can be either a genetic factor or a metabolic factor, which are listed over here. Two abnormal morphologies which are more researched are central granularity or central pitting and SCR aggregates. So central granularity, this is the oocyte which has a central granularity which can be transferred from oocyte to the embryo as well. Occurrence of the reason for it can be a sign of cytoplasmic immaturity, patient age, gonadotrophin type, stimulation protocol, and pesticide exposure also needs to higher central granularity. Coming to smooth endoplasmic reticulum aggregates, higher chances of SCR when there is a longer ovarian stimulation cycle, higher serum progesterone, larger follicle at trigger, and higher number of retrieved oocyte. So coming to the conclusions of case 4, maturity and morphology both matter for the oocyte quality. Dual trigger gives higher number of mature oocyte. Immature oocyte syndrome or EFS, we can give double trigger and delayed OPU. Controversy exists regarding morphological oocyte quality and IVF outcome. Many of these abnormalities might be physiological effect or a patient factor, and central granulation SCR aggregate may affect the IVF outcome. The overall conclusion, let us anticipate rather than be surprised. So start with a marginally higher dose after proper dose calculation. Routine pre-IVF day 2-3 scan to check for AFs and treat the variation in the follicular sizes if any. Give antagonist on time and stop checking the LH levels. In previous history of premature ovulation, do 34-hour egg pickup with NSAIDs and explain the warning sign to the patient. Advise couple to avoid endocrine disrupting chemicals as much as possible like plastics, and routine dual trigger for poor and normo responder should be advisable. Thank you for your patient hearing.
Thank you, Dr. Sankalp. It has reminded us that IVF is full of surprises. Now, we move on to another powerful tool. May I please request Dr. Sankalp to once again come to the dais to accept this memento. May I request Dr. Sheila Balakrishnan to kindly present this memento to Dr. Sankalp Singh?